Hi, this is Brian Kim. I'm going to share with you case number 11 in the best way to do cataract surgery series. This is actually the second eye of a 92-year-old lady with a 3 plus nuclear sclerotic cataract. Her first eye was done in case number 10 in the best way to do cataract surgery series, and I did that modified stop and chop technique. I decided to do the typical double chop, cross chop, mechanical fracturing technique without using any sculpting on this second eye, just to show you the difference in the different technique. This patient also had a strong upward Bell's reflex, and normally in the right eye, I can use a cannula to hold the eye steady. However, it's a little bit trickier on the left eye because since I'm a right-handed surgeon, using the cannula through the side port incision is a little bit more of a challenge. So I'll show you how I use the cannula to hold the eye straight for a left eye with a strong Bell's reflex. I use a corneal marker to help me size and center my rhexis. I make my paracenteses incisions and then fill the eye with intracameral lidocaine and then dispersive viscoelastic. As I'm injecting this viscoelastic, this is the left eye. You'll see that the patient has a little bit of a Bell's reflex and the eye is rotating upward, which is towards the right. So I'm going to use the cannula and twist the cannula and pull the eye towards the left, which is downward. And so by torquing the cannula, I'm able to straighten the eye to allow me to do my triplanar corneal incision. I make a vertical groove and then tunnel and then enter into the anterior chamber. But this is the most important thing. I'm able to use the cannula by torquing it in that manner, and I'm able to rotate the eye downward. This gives me tremendous control of the eye, and it allows me to keep the eye centered and straight. As you can see, I'm using the cannula still to hold the eye straight so I can do my capsulorhexis. I do a puncture style capsulorhexis using my forceps to puncture centrally, pulling down and then sweeping to the right in order to create a little bit of a C shape. I grab the rhexis edge and start going around. Again, you can see the cannula is actively keeping the eye straight. I'm pulling it down, which is towards the left. I'm re-grabbing very carefully from my capsulorhexis. I'm using the corneal marks to help me size and center my rhexis. And so you're able to keep the eye straight in an atraumatic way without having to use forceps. As you can see, as soon as I come out, the eye just goes straight upward. I use my right-angled cannula to perform the capsular fornix hydrodissection. I place a cannula out to the equator, point it towards the nerve, push fluid, and it propagates nicely. I decompress it to the left, and you can see the lens spins very nicely. I lift the incision with my chopper to enter the eye and minimize any decimace trauma. You can see I exposed more of the phaco tip because this is a dense lens. I'm going to initiate the double chop and place the chopper out to the equator, turn the phaco tip more vertically. I'm going to crush this lens by bringing the chopper and phaco tip together, and you can see the lens is completely fractured. I'm going ahead and stretching, making sure it's completely separated. I did the cross chop, place the chopper out to the contralateral equator, and then pulling the chopper to the center, and I'm crushing and chopping the right heminucleus. I'm initiating more mechanical fracturing maneuvers by bringing the chopper out to the equator and then bringing it to the middle, crushing the lens material between the chopper and the phaco tip. I'm initiating now the ultrasonic energy and vacuum. Again, I'm using just pulses of energy to minimize any CDE, ultrasonic power. I'm crushing the lens again, and then using, again, bursts of ultrasonic energy and vacuum to evacuate the lens material. I'm doing successive crushing maneuvers, again, crushing the lens material little by little, and by doing so, I'm able to really minimize the usage of ultrasonic energy. Here's another cross-chop maneuver, placing the chopper out to the equator and crushing this other piece as well. I'm grabbing it and then crushing the lens between the chopper and phaco tip, and then emulsifying the pieces once they're in smaller bite-sized pieces. I initiate another cross-chop maneuver, placing the chopper out to the equator and crushing that lens fragment. I'm using successive crushing forces, again, mechanical fracturing, crush the lens between the chopper and phaco tip. And once the pieces are small enough, I'm emulsifying it using little intermittent bursts of ultrasonic energy and vacuum. Now, half the lens is completely removed, and the CDE is only 1.57 in this dense lens. I'm placing the chopper out to the equator and then placing the phaco tip deep within the bag, and then I'm separating the lens pieces, making sure they're completely separated. Again, I'm using another mechanical fracturing technique, placing the chopper out to the equator and crushing that lens fragment and dividing it again. Once the pieces are divided, I'm using, again, successive crushing forces using the chopper and phaco tip to crush the lens pieces into smaller bite-sized pieces, and then using the vacuum and ultrasonic energy and emulsifying the lens pieces. This is the last quadrant, placing the chopper out to the equator, placing the phaco tip deep in the bag, crushing the lens completely, and then crushing these lens pieces into smaller bite-sized pieces. Again, the technique is all about placing that chopper out to the equator around the lens piece, crushing it between it and the phaco tip, and the lens fragment breaks very easily, and then using multiple mechanical fracturing forces to again sandwich the lens pieces, crushing them between the chopper and phaco tip until they're small enough bite-sized pieces, and then using bursts of ultrasonic energy and vacuum to remove those pieces. I'm on the last bits here. Again, I'm just using the ultrasonic energy and vacuum, again, sparingly and wisely, making sure that my chopper is deep in the bag. I always prefer placing that chopper in the bag, deep between the bag and the phaco tip as I remove those last pieces. I'm pushing BSS and I'm doing a fluid exchange, basically pulling the phaco tip out and then quickly with the INA tip. I like to start subincisionally with the INA tip, again using this polymer tip, and then I'm going around circumferentially, pulling the cortical material off. With this machine, I'm able to generate quite a bit of aspiration and vacuum, and I feel really confident with this polymer tip. After all the cortex is removed, I start to polish underneath the anterior capsule surface. I want to be able to polish and remove as many lens epithelial cells that I see. I'm polishing all the way around circumferentially, and then I start polishing the posterior capsule as well to remove any lens epithelial cells. I think this helps minimize capsule contraction and also helps reduce PCO. I'm using a cannula to pulse fluid into the capsular fornix subincisionally. Sometimes I can see some cortical wisps or dust bunnies. I switch to the cohesive viscoelastic, pushing it to expand the bag, and then I'm using the sweep to again polish underneath the anterior capsular surface, first on the left side and then the right side. I'm injecting a 3-piece hydrophobic acrylic lens. I push some more viscoelastic to open up the bag, and I'm injecting the lens and then using a Maltzman to dial the trailing haptic into the bag. I use an INA handpiece to evacuate any viscoelastic underneath the lens, and then I hydrate my incisions. So this is a case, again, a 92-year-old lady who had her first eye with a modified stop and chop technique. The CDE was not too high, it was still around 6 or 7, but this is showing using double chop and cross chop and mechanical fracturing. You can see the CDE is 2.55. This patient had a perfectly clear cornea after surgery. The maneuvers are very controlled and very careful and methodical. You also saw an example of how you can pull an eye down without using forceps and traumatizing the eye tissue. You can use a cannula to torque it and then pulling the eye down using your cannula. And you can do this either with a left eye or a right eye with this technique. I am a firm believer that the double chop and cross chop and mechanical fracturing is the best way to do cataract surgery, and I hope this was helpful to you. Thank you for your attention.